Well, a warm welcome to this talk. It's Friday the 22nd of July. Now, it's impressive how BA5 is just running rampant through the world. It's just everywhere and it's infecting huge numbers of people. It's outcompeting BA4 and of course it's outcompeting the previous BA2s. Now, what does this tell us about future variants? Well, I don't think it tells us very much. It tells us there's big unknowns. I think what we can say is any future variants will probably not be more transmissible than these Omicron variants because they're already immensely transmissible, but it could mean that the next variant to become prolific is one which is able to escape the immunity generated by the Omicron variants and indeed the vaccines and all the previous waves. And to be fair, we did predict this some time ago, so there's nothing surprising, but let's look at some of the data. It's quite impressive and there's a few interesting other bits and bobs to talk about as we go along today. Now here's some data here. Now this is CDC variant data. Now BA5, wow, it's 78% basically now. BA4 already down to 12.8, something like a 25% competitive advantage in terms of immune escape with BA5. BA2 12.1, which we did and ah about that. We weren't sure where that was going, but now clearly it's on the way down, being outcompeted clearly by BA5. BA2 is down to 0.6%. Impressively low numbers now. And the other ones, the BA1, the Delta and the others, just aren't registering on the CDC website at all. And when we have a look at this graphic really does sort of pack a bit of a punch really. Let's just look at that now. Here we have it. So this is the nowcast from the CDC. So it's really quite mathematical. The reduction in BA2 there, the reduction in BA2 12.1 there, and BA5 here, it really is, you could almost draw these lines up with a ruler, couldn't you? It really is quite impressive. We did predict this. It's gone maybe a little faster than we thought. We weren't sure initially whether it would be BA4 or BA5 together, but about 3 weeks ago now it was clear that BA5 was outcompeting BA4, also causing some hospitalizations, some increase in hospitalizations, a very slight increase in intensive care admissions in the United States and the UK. But I think this is due largely to the incredibly large numbers of people being infected, as we will see. And the other thing that is concerning is it's causing slightly less long COVID than Delta, but not much. So about 4.2% of people are getting long COVID after Omicron, as opposed to about 5% with Delta. But there again, we have much more immunity now. So the long COVID is becoming quite significant. And I was just reading today that the UK, for example, has got the highest sickness rate basically in the developed world. There's so many people off sick with chronic ill health, and a fair chunk of that has got to be attributed to self-reported long COVID. But let's go on with the details. So that was that graphic there, pretty interesting. New reported cases in the United States. Now, clearly it's gone up a bit, but not much because we know that the testing is very, very limited. Test positivity rate, however, is up to about 18% there. Now, as you probably know, the test positivity is the proportion of tests that come back positive as a percentage. And the higher the test positivity rate, the more virus there is in the community at that time. So the test positivity rate is how we're pretty sure that BA5 is very high in the States, as well as this testing from the CDC, rather than the actual testing, because the testing's not really done. So it's the percentage of tests that are coming back positive that is more accurate. So that is pretty high, as we can clearly see. Hospitalised in the States, well, it is up a bit because of the very large numbers of people being infected. Nothing really to say that it's greater pathogenicity. It's just the sheer numbers are being infected. It's kind of a percentages effect or percentages game, really. It's not a game to the people involved, but a percentage of the overall infections, because the overall infections are so high at the moment. So that's the hospitalised. Now, deaths Well, you can see there that they're up a little bit. And considering the sheer numbers of people that are being affected, it does show that the population has acquired quite a high degree of immunity. In the UK, for example, we're about 97.5% of people currently have antibodies. It's been as high as about 99.3%. So virtually everyone has had some level of exposure. We don't have the naivety to this virus that we had way back in the unknown days of early 2020, for example. So that's the deaths. Risk of vaccine and in the vaccinated, unvaccinated. Now, this is CDC data presented via the New York Times graphics in this case, but it's showing that CDC data, make what you want of this, but it is based on reasonable statistics. Unvaccinated have a 6 times higher risk of death. Now, we can see that gap there has been much higher in the past. Way higher likelihood of death in the previous waves, but now it's down to about this because of the amount of natural immunity that is around, I would submit. So that's the death. Now, moving hospital risk admission goes up with age, of course. So this is the higher age groups here. This is 70 plus, and this is the last 90 days. In the younger age groups, progressively less. And that dotted line there is actually all ages. Now, that's the averaged out over hospital admission. So we do see a slight increase, but we do see, and this is important to grasp here, a disproportionate increase in the older age groups. And we're seeing the same in the UK. That's the hospitalised and the intensive care figures. So we are seeing some increase in intensive care admissions. Now, we are seeing this in the UK as well, but it's pretty small numbers. And we know that from the UK data, around about 40% of people that are admitted to intensive care are admitted with COVID, not for COVID. And there's no reason to assume that the statistical, the stats would be that much different in the United States. Now, a certain resident of Pennsylvania Avenue, Mr. Biden is actually 79. He's tested positive for COVID. He is undertaking light duties. We believe he's being treated by his doctors, and we can assume he's being closely observed. As far as we know, his condition is mild. He is taking Paxlovid. He's had his full 3 vaccines and 2 boosters, and we wish Mr. Biden well, of course, as we do with everyone who has this infection. But it is interesting, the White House took pretty strenuous measures to protect the president, and yet you still got it indicating just how transmissible this is. And as we see, it's an 80% chance that Mr. Biden's infected with BA5, smaller chances infected with BA4, and virtually no chances infected with BA2 or BA1. So it just shows the sheer transmissibility that we are dealing with here, that the President of the United States can't be protected. So thankfully, mild symptoms. Hopefully make a full recovery. Now, the Office for National Statistics data from the UK. Staggering. Now, just before we look at this, these are the overall figures. England 1 in 17, Wales 1 in 17, Northern Ireland 1 in 20, Scotland higher, 1 in 15 people currently infected. But this represents the peak. Next week, and I'll show you why this is, next week we can say with confidence these figures will be going down. So the Office for National Statistics data, always about a week out of date, is now at its peak. And I'll be giving you the evidence for that. England, well, there we see the increase here as we expected, but not as steep an increase as it has been. Here we see Scotland, and again, we're starting to see a levelling off now in the Scottish data. Number of cases in Scotland. Now, rate of reinfections is interesting. Now, let me just show you what this graph here is. These are rate of reinfections per 100,000 people, participant days at risk. So it's the number of people and the number of days they're at risk. So, and these are the infections. So we see it was low, of course, in Delta. Then we saw the risk of reinfection increase massively in Omicron times, as we know, but now it's starting to go down a bit. And although that's not a significant drop off there, I do actually see quite a lot of grounds for optimism in that, indicating that there is some immunity to Omicron being generated by Omicron infections. Not as much, of course, as we would have liked, because we know that people, for example, are getting BA5 after recently getting BA1 or BA2. But perhaps some early indication of encouraging data there. Otherwise, we're going to be on getting reinfected with this forever. It's a bit of a depressing prospect, really, but I don't believe that's going to happen, because we are going to develop more and more natural immunity, and this is going to become milder and milder. Now, long COVID, as we said, this is a concern. This is the coronavirus infection survey, 6 to 12 weeks after initial infection, and these are all laboratory confirmed infections from this national infection survey. Now, people still complaining of symptoms after 12 to 16 weeks. With BA1, it was 4.5% of total infections officially diagnosed, pretty high. BA2, 4.2, Delta, it was 5. And as we say, this is probably largely due to the increased level of immunity. So we were very hopeful that because Delta seemed to be presenting more mildly, that it was a less pathogenic virus, but this seems to be, that's true to an extent, we still believe that, but it's largely making people less ill because they had previous immunity. And it looking like that the risk of Omicron causing long COVID is similar, or very slightly less than Delta, which is surprising and immensely disappointing, as the high sickness rates that we looked at the other day evidence quite clearly. So pretty disappointing for long COVID. And this is in adults that are triply vaccinated. So we have to say that the vaccines are not providing a good level of protection against long COVID. Now, we don't know what this will be in the unvaccinated group, because we're not given the sample to compare it to. But with triply vaccinated, we're still getting 4%, 4.2% long COVID. Very disappointing performance from the vaccines, I would say, in terms of protecting us against long COVID in the 12 to 16 week range. Hospital admissions in the UK as of last week starting to level off. Now, the very latest data from the UK, the very latest data is starting to show a slight reduction in hospital admissions and a slight reduction in total people in hospital, but a slight increase in the number of people going into intensive care. Slight, but it is there. So hospitalizations look like they've just peaked. Cases are going to start going down next week in official data, and in a week's time and 2 weeks' time, hospital admissions will be down. This trend is certainly there, unless we're completely wrong, but we've been able to be fairly confident about this because of the established trends now. It's not being particularly clever. These trends are clearly established. So we will see a reduction in hospitalisations in the UK over the next few weeks, and hopefully in other countries as well. Although I've just heard, I haven't checked the data yet, but New Zealand has got an increased death rate at the moment. But okay, there's differences by a few weeks, but this BA5 surge is pretty well synchronized in all parts of the world. It's just gone around the world so quickly. So such a quick, incredibly quick, really quite surprising. Generated by the immune escape, which is profound. Right, intensive care admissions up, as we said, very slightly, but only slightly. Number of deaths in the UK, again, up slightly. These will carry on going up next week and hopefully go down the week after. Thankfully, nothing like the previous appalling waves that bereaved so many families. And how do we know we're pretty confident that it's going to go down? Well, there we go. The Zoe data has gone down. The Zoe data is up to date. This is on the day. So I've taken this Friday, the 22nd of July. I've just taken this off the website. And there we go. A bit of a blow up just to reassure ourselves that it is starting to go down. And it really is quite a smooth curve, as we saw on the previous peak with the original or the earlier Omicron wave. We are seeing the same as the large-scale data smooths itself out. So be encouraged by that. We are at the peak now, and the official data will show that very shortly. Japan, just to give one brief example, highest level of vigilance required by the Japanese government. New wave of infections is BA5, of course. Compared to the cases they've had, they're way up. Interestingly, in Japan, disproportionately affecting children and younger people. Now, Japan is interesting. There's something strange going on. They've had very low levels in Japan. So, for example, in Japan, and this is just one of the thousands of things that are going to come out of this pandemic, they eat a lot of seaweed. I've been looking for seaweed in my supermarkets and can't find any. Seaweed's very high in iodine. When you eat iodine regularly, that tops up the thyroid gland. It fills your thyroid gland up with this iodine storage or thyroxine storage molecule called thyroglobulin. Then when that's full, the iodine starts spilling out and goes into your blood. And if you've got free iodine in your blood, that iodine goes into your mucous membranes, your nose, your mouth, gastrointestinal tract. And iodine kills all, let me say that again, all viruses. Iodine at sufficient concentrations will kill all viruses and all bacteria. So what we need to do is have a study where we look at people on high iodine diets like in Japan and analyse their mucus. This would be such a simple study to do. Why aren't Big Pharma doing it? I can't think. All we need to do is take some saliva and some mucus from people in Japan, from 1,000 people in Japan. Take some saliva and mucus from 1,000 people in England. You can have some of mine, or the United States. Come and get mine anytime you want. And compare the amounts of iodine in it and see if this theory is correct. Because if it is that there's more iodine in the mucus in Japan because they eat more seaweed containing more iodine, how simple would that be to massively reduce global morbidity and mortality from viral and bacterial diseases? Why is this research not being done? You can answer that question yourself. But I would point out that iodine is dirt cheap and the sea's full of it. Opportunities, real opportunities to really, really help the global burden of suffering, pain and death. Wish someone would do that. If you're an academic watching and you've got it wouldn't cost a lot. What would that cost? You could probably do that for $100,000 quite easily. Quite easily. Anyway, enough of that rant. Japan, so there is some increase in the over 60s, fair enough. So lowest rate per capita in all the OECD countries. The rate is is 246 per million. So pretty low rates of infection, pretty low rates of death. So anyone who's got a research budget, do that study. Such a simple thing. Then we could get, all we need to do is start feeding people seaweed or iodine supplements, and we would know the answer to that question, wouldn't we? As of now, we simply don't know. Anyway, enough of me ranting on for today. But it is really frustrating that these simple things, pick the low-hanging fruit first, then do your clever clogs molecules after that. Let's get the basic things right first. A dietary supplement that could massively reduce viral infection all over the world, I'm in for that. Thank you for watching.